Yep, was able to record it.
Awesome. Okay, so thanks everybody for jumping in. We always record this and send it out for people that can't make it live. People like that. So Matt, get excited. Most of our clients are going to end up watching this. If you are not watching this live, you can, whenever you watch this, even if it's in 2022, you can email any questions that you have about your particular labs or anything here in general. I'll just give like a real brief intro. Just from a vital signs standpoint, we're really passionate about patient data. If you've been with us for a little bit, you know we've always provided labs complimentary or at cost with our programs. Your body fat percentage may change over time, but the knowledge that you gain as a consumer should stay forever. And so we want people to engage their healthcare, physical, their just kind of all of their healthcare procedures with the most knowledge that we can provide. So we're really excited about making this advanced panel more part of the discussion, and we really think it's the standard of care for liver health, for cardiac health, all that kind of stuff. So without further ado, I'll just I'll kind of let Matt introduce himself, but Matt is a longtime coach. He's our director of corporate and operations here. He's really knowledgeable on this stuff. None of us are cardiologists, but Matt's arguably better in some ways. So we love having him on board. If at any point you got any questions, y'all can just kind of jump in. We'll have about a 20-minute presentation from Matt, and then we'll have the rest of the time will be Q&A. So Matt, you want to take over for us?
Yes, thank you, Andrew. I appreciate the introduction, and as always, your unparalleled charm. So hello, everyone. I just want to say thank you for joining us today. So I'm pretty excited about this training, maybe just because I'm a cardio nerd, but that's okay. Maybe you guys will be by the end of this. So the title you can see is Understanding Lipids and CVD Risk, so cardiovascular disease risk. Quickly, again, my name is Matt Rogers. Quick background, master's in applied exercise physiology, certified exercise physiologist through the American College of Sports Medicine, and an exercise medicine level 2 credential also through American College of Sports Medicine. I've been in the industry, health and wellness industry, for 15 years in multiple capacities: health coach, screening technician, owner, operator, personal training company. The list goes on. I won't bore you with all that. So my passion specifically, quickly to the scope of the conversation, is disease, its manifestation and reversal. So I like pathophysiology and how it manifests in the nerdy stuff. So we'll get into that, so be excited. Excellent. So let's get into the meat of this. My screen will, what is happening? Why won't my screen? Oh, there it goes. Okay. Whew. All right. So I'm going to give a little background on how we got to NMR, because a lot of you guys went and did NMR Lipoprofile panels. So you're probably saying, why did I go do this? It sounded cool, and maybe Andrew encouraged it. So let's explain why. So first, I want to start off to give a contextual background. What you've been doing your whole life is the quote standard lipid panel. Arguably, it's a disservice to almost everybody because it's very antiquated and does not give you nearly enough data to make a sound clinical judgment, in my humble opinion. And then again, just for recording purposes, let me just give a brief disclaimer, as Andrew said before. So I am not a physician or a cardiologist, nor do I claim to be. So just get that crystal clear. This is not for medical advice. It's just my formulated professional opinion over my span. So standard lipid panel, you guys do it with vital signs in your metrics. You do it when you do a physical exam with your provider. So it's the quote standard of care. So first point there, it is antiquated technology developed in the late 1960s. So it's been around a long time. A lot better stuff out there now, hence the NMR Lipoprofile. So here's the point of all this, though. We're looking for tools in the disease risk toolbox. So a standard lipid panel is one tool, in my point there, in parentheses, arguably the least effective tool. So what do you get in a standard lipid panel? You get TC, LDL, HDL, triglycerides, VLDL, and ratio. So in short, stuff you guys already know: total cholesterol, your low density lipoprotein, your high density lipoprotein. So that's a good versus bad argument right there that we'll get into. Triglycerides, which is not cholesterol, technically it's a different molecular structure. VLDL, which is your very low density lipoprotein, and then your total cholesterol to your HDL ratio. So that's all you get in that panel. Here's the point, though. Most physicians just put the LDL on a pedestal and just want to treat and diagnose off of that. So they undermine everything else in the panel, which is a disservice to you as a patient. So LDL is one factor, not the end all be all factor. So I just want to point out quickly in a standard lipid panel, when your HDL is a 60 or higher, it's actually optimal and serves as a negative risk factor. So that's very important, and that gets glossed over very quickly when you have conversations with your physician. So I just wanted to bring that point out because it is very relevant, and often many providers don't care, frankly. LDL is 102, let's get you on a statin. Andrew, you got a question? I see you unmuted.
Yeah. So what I was going to say is everybody sort of knows the LDL is bad cholesterol. And you see your LDL is bad, your doctor will often be looking to write you a statin. But even, is this true or false? Even traditional medicine would say that a good HDL is a better sign than a bad LDL is a bad sign. Is that correct?
So I would argue absolutely, and I think the literature supports that. So then the fundamental question is, why don't physicians have that lens? Well, that's a whole nother conversation. We should probably do a video on that, frankly. So perfect example. So what do we talk about a lot with disease manifestation? Metabolic syndrome, right? Knock. LDL is not a criteria for metabolic syndrome. Low HDL is. Isn't that interesting? But nobody wants to talk about that. Well, I think we should talk about it. So anywho, either the group's going to really like me quickly, or they're going to be like, this guy is a whack job. But that's okay. I don't have many feelings, so you can't offend me. All right. So good question, Andrew. Thanks for bringing that up. So next, I just want to point out some other tools in the disease risk toolbox. Again, when you build a home, use a lot of tools. You wouldn't just isolate yourself to just one line of tools or one brand of tools. It makes sense to deploy every asset you have at your advantage to make the best product. In this case, the best clinical decision. So Andrew is going to be gracious enough. I think he's going to follow up with you guys to send out the link to that 10-year risk calculator, which is my first point there. So that's a 10-year risk calculator for event risk, specifically a vascular event such as a heart attack or a stroke. So that's a really cool tool. And the main point behind that is if statins are, quote, medically warranted per the calculator. What I mean by that is there is a standard of care percentage in that calculator to say that you are now a candidate for statin medication. So my point is a lot of people will be at a 3% risk and they'll be on a statin. I said, why are you on a statin? Oh, my doctor put me on one. And I go, did they tell you about the 10-year risk calculator? They go, the 10-year what? I said, we got problems. So I won't get into much behind that, but Andrew will follow the link, and I would encourage you to go on there and put your metrics in and see what your risk percentage is on that 10-year extrapolation. So it's actually quite fascinating. Next is CIMT testing. That's carotid intima media thickness. So it's carotid ultrasound, which is going to give you an assessment as far as where is that disease with respect from your heart, because cardiovascular disease is not, or arterial disease is not just isolated locally with respect to the heart and coronary arteries. It is a systemic disease. You get it in the periphery, you get it cerebrally, you get it in other artery systems. So the point is, it's another tool in the toolbox that you should be utilizing if you are at increased risk or a candidate for heart disease, if it runs in your family history, if you've already had markers flagged, et cetera. Just if you haven't had that conversation with your physician, I would implore you to talk to them essentially about everything we're talking about here. Next, coronary CAC, coronary artery calcium scan. I'm sure some of you probably have already done this test. So it's a CT of the coronary arteries, pretty quick test, not invasive. So it's going to give you a number as far as calcification within the coronary arteries. So best score is 0. So that's obviously the goal. Again, another tool in the toolbox. Next one we're going to talk about in detail on the next slide here, NMR Lipoprofile. Cardiac catheterization. So basically you look at arterial perfusion. So the rate of blood flow. So is there a delay? That's indicative usually of ischemia. There's an obstruction. So why is that there? Because you have disease manifestation. So it's another test. I'm not saying go run out and do a cardiac cath for the record. I'm just saying that is a test. And if you are being treated, you probably have done one. And another one, exercise stress test. There's different methods. So you have your standard treadmill exercise. Then you have nuclear, which is basically a pharmacologic intervention or modality of the stress test. And then PET. So I want to make a quick delineation between these two, and then we're going to move on. Exercise stress test is about 75% accurate. A PET stress test is 94% accurate. And if you ask, why have I never done a PET stress test, is because that's not the standard of care. So again, if you are being treated currently for cardiovascular disease and you and your physician come to you're at increased risk, I would implore you to do that test, because all those other tests, the tools, that's while at rest. So that's one factor. The bottom one, the stress test, is while your system is loaded. And if we're vital signs people, we're always talking about loading, right? We're going to load the body. We got to apply an external stimulus to get an internal adaptation. So just keep that in mind. So
Matt, can I throw a couple things on real quick?
Yeah, buddy, go ahead.
If you can go back to the last slide, the one thing is for disease risk, because we're talking about determining disease risk, obviously, family history is going to go in here as well.
Correct.
Um,
Yes.
so if you've got a family history, like I guess like from my standpoint, that one of the takeaways, if you've got a family history, certainly don't just rely on that LDL, right?
Yes.
Then the NMR, and then maybe like a calcium score. But but it's kind of like Swiss cheese. Some of these are going to catch your risk, and some of them are going to maybe miss it. So just like on one example, the calcium score is basically the objective measure of, in your whole system, how much, in your whole vascular system, how much is there calcified plaques in there? And it might be 20% of your system is calcified. But if you have a low calcium score, but you've got has anybody heard of like the Widowmaker, or like it's called the left anterior descending artery? Yeah, this is when the person just sort of drops down of a heart attack. Well, you don't have to have a big blockage. You don't have to have a high calcium score to have an issue with that. You just have to have calcification in that one spot, in that left anterior descending artery. So again, and if that in particular, if that LAD, Widowmaker, is in your family, a CIMT might be something you want to add on to there. So, and anyway, so again, you're probably going to want several of these confirmations, especially if you got a family history. The last thing I'll say, Matt, is just something really interesting that I spoke about with Dr. Purdue recently, is that if you talk to like the vascular surgeons, everybody knows that the two biggest causes of well, maybe not everybody, but the two biggest causes of heart disease, historically, the number one cause is smoking, right?
Yep.
And that causes a blockage in your arteries. Well, if you talk to vascular surgeons who will help smokers, what they can do is find where there's a blockage in their vascular system and then just pass around it. But if you look at, or if you ask a cardiovascular surgeon, what about a diabetic's vascular system? Well, the entire length of a blood vessel in a diabetic is compromised and blocked up. Whereas a smoker, it's usually just in one area that you can bypass. So all that to say is like the underlying metabolic risk factor can compromise your whole system in a way that's much different than how we see cardiac risk with like smoking.
100%. Yes. So the fundamental point is we're using a plethora of tools to be proactive and prevent exacerbated disease manifestation if it currently exists. But ideally, we don't want it to ever exist, but that's the whole point in using the whole arsenal. You can't just, like I said in the beginning, you can't just use a standard lipid panel for 35 years, and then on year 36 you got heart disease. Hello, so yes, to your point, yes, use all the tools and have a very open, honest dialogue with your physician. If you go into your provider's office and you're concerned about heart disease, particularly like to your point, if you have family history, so you have a genetic predisposition to that pathology, and you start talking about these things and he gets like offended or thinks you're like, that's a red flag. Whoa, we're here to talk about me and my health, and I want to talk about, do you think these tests make sense for me? And if he says no, that's fine, but you should have the expectations. You better articulate logically with rationale why those don't make sense for you. That's all I would say personally. So thank you, Mr. Lawrence. All right, so NMR Lipoprofile. So what is the intent of this test? Because it gets different numbers, right? So basically it's to quantify the totality of your LDL-C, because in the standard panel, you're going to get that LDL-C, LDL cholesterol, which is all of the cargo, okay? So we're bringing stuff, we're loading stuff, and we're moving it, transporting it, because what is cholesterol? They are transport vehicles, transport molecules, they carry stuff. So what is the totality of the cargo? So the number of vehicles in this mass transit, so to speak, that's going to be your LDL-P per particle, okay? I think that's actually the first number on the test, if I remember correctly. But and we're going to talk about the results of that here in the next slide. But so LDL-P particles. So again, the totality of cargo, all the vehicles in the mix here. How many vehicles I got? I got a lot or not a lot? And then what about the vehicles in that cargo? So small, dense, or large, buoyant, or fluffy. So the LDL particle size, and we're going to get into that. So because that matters. So the results. All right. So LDL particle. I put two thresholds here. For high risk and moderate risk. So high risk, you got family history, you're being treated, you're probably on a statin and arguably probably on a hypertensive medication. That would probably qualify you for high risk. It's gonna be a little bit more of a stringent guideline for that, obviously, because you're at increased risk. So we have to be very proactive on the threshold. So under 1,000 would be optimal for high risk. Under 1,300 for moderate risk. Now, granted, I just want to note for the record, however, we should always be striving for optimal, because what is that going to do? That's going to reduce disease risk. For example, in vital signs, we'll flag you for an insulin over 10. LabCorp is not going to say that. That's not going to get red flag. But we're looking for optimal. Why? Because we want to be proactive and prevent. We don't want to wait till you're 24.9 and say, well, if I was at 25.0, I'd be red. We're getting pretty late there. So why wait? And again, if we want to mitigate disease onset. So again, so that's kind of the rationale. So again, always striving. So if you have no risk and you did a particle test and you came back at a 1242, you don't have to be really that concerned, because that's still relatively a low risk threshold. But again, don't settle for that. Don't be like, it's not bad, I'm okay. Push yourself to be optimal with respect to all of your clinical metrics. Next, particle size. You probably remember the language pattern A, pattern B. We want pattern A, we don't want pattern B. So pattern A is low risk. That's gonna be your large, fluffy or large buoyant particles. So you can think of it like metaphoric as like a beach ball. So you got beach balls floating around your arteries. They're benign. They're not gonna cause structural integrity to the endothelium, right? The lining of the coronary arteries. That won't hurt it. Now, pattern B is very high risk, and you don't want that. So you can see that the threshold is gonna be for pattern A, you want that to be 20.6 or greater, which will be indicated on the panel. So higher is better for that number. And then pattern B will be indicated as 20.5 or less on the panel. So we don't want that number or lower. So we'll be higher on the pattern on the LDL size there. Again, so you could have a flagged, I want to be clear, you could have an elevated LDL cholesterol on your panel. So it could be red flag, over 100 would be red flagged. And if you did NMR Lipoprofile, it could come back totally textbook. It could come back bad, but it could totally come back totally benign, which then further solidifies you wouldn't need a statin, for example, to go down that road. So that's why it's good, again, to deploy the tools, not just stop at a lipid panel. HDL particle, right? We all talk about HDL. That's our good cholesterol. We want a lot of it, and that's accurate. We do. It is our good cholesterol. We do want a lot. So there is a particle count for that as well. Higher is better, because that means you have less of the LDL particles. So hence why it's your good cholesterol. So we want a higher HDL particle number. So I put a good goal of 35. I don't know if that's clinically defined. That's really I don't say arbitrary, but it's gonna significantly reduce disease risk if you're a 35 or greater for that HDL particle. Small, it's gonna put you at the better percentile, is what I'm saying. Small LDL particle. So again, lower is better, because you don't want a lot of those. Again, those are the bad guys. That's gonna cause endothelium damage. So again, the small dense particles, okay, so pattern B, the ones we don't want. Think small BBs, okay, so they have a penetrating force that is going to compromise the structural integrity of the endothelium, right, your lining of your coronary artery. And once that happens, that produces a whole onset of pathophysiology, which we're going to get into, I think, in the next slide. So my biochemistry people get excited. HDL part. So yeah, so again, so a good goal for LDLP, and again, I put a good goal, meaning we're striving for optimal. It doesn't mean if you're higher than that it's bad or red flag. I'm not saying. I'm just saying a goal we're striving for. About 100, under 120. Again, it's going to put you at better percentile, which is going to reduce your disease risk for cardiovascular disease. And then the last one here I put it, which very important one, very important one, is your LPIR score. So it's lipoprotein insulin resistance score. Lower is better, obviously, because higher means what? You're insulin resistant, which means what? Manifestation of disease, particularly metabolic disease, type 2 diabetes. And to Andrew's point earlier, diabetics, cardiovascular or vascular system is very compromised, because it is a systemic issue. Because why? We have glucose floating around the whole body. We have extremely high elevations of glucose floating around our circulatory system for very long periods of time. What does that do? It causes serious damage, especially if untreated for a long period of time, which it's slightly off topic, but now I'm getting fired up and Andrew has that effect on me. A point to note here with respect to diabetes and cardiovascular health, when you're being treated for type 2 diabetes, quote, the standard of care, a good treatment management goal is a 7.0 A1C, which is complete hogwash. Because why? You still have elevated glucose, which does what? Causes arterial damage. So you still have cardiovascular risk factors there that are not being addressed, but your A1C, I can check the box as a provider because I got you out of 7, And the American Diabetes Association said I did a good job. So hopefully that makes sense. Does that make sense, Andrew? He gave me a shake.
Absolutely.
Okay.
So basically the excess glucose in your system, if you have uncontrolled glucose or even just high glucose, you're creating an environment for arterial damage. If you've got those little bullet small LDLs penetrating, that's also causing arterial damage. And then if you're inflamed, because most Americans are inflamed,
correct. Yep.
Then you've got sort of damage to the structure of your blood vessels.
Yep.
And then they're being pressed on, and then it's really easy for things like plaques to get lodged into your vascular system.
Correct. It creates the perfect storm. Correct. Absolutely. Yep. And so we're going to get into that in the next slide, but you hit it in a high level nutshell. Correct. Absolutely. So what are the key takeaways from the NMR results? Again, it's going to be LDL particle number. How many vehicles we got in here? Less is better, under 1,000. LDL size, are these vehicles going to hurt me or are they benign, low risk? I don't got to worry about them. Again, small, dense, very bad, like BBs, large, fluffy, totally okay, like a beach ball. And then the LPIR score, again, lipoprotein insulin resistance score. So that's going to be the precursor to type 2 diabetes and its earliest signs of measurable manifestation through changes in the lipoprotein. So that's key. So my point is, if that LPIR score is starting to increase, it can still increase with a normal glucose and A1C. So it's a very earliest onset measurable manifestation of insulin resistance. So it's very key takeaway point here. So you can have as it elevates, you can still have signs on another panel, like just fasting glucose and A1C, that are still within the normal metric. So, and a lot of times we're just going off of that. So we're like, we're good. And that's not always the case. It goes back to use all the tools in the toolbox to make your most sound clinical judgment, especially if we're actually in the active process of treating disease. This is another one here. This one is not on the panel. But it is important. Now, some providers might have a thing to say you don't really need that one. You can kind of speculate and make a good judgment without it, and maybe you can, maybe you can't. But anyways, I want to put it on here for the purpose of the scope of the presentation. So LDL, so it's oxidized low density lipoprotein. Bad, in short, bad. We don't want that. So what happens is a normal LDL particle, it gets damaged via free radical exposure. Okay, which goes back to points Andrew was making. Inflammation is going to trigger free radicals, and then we have basically a chemical recomposition of that structure, and now it's oxidized and becomes very harmful. It's going to increase the risk of ASCVD, atherosclerotic cardiovascular disease. Again, we don't want oxidized LDL, and it will hurt other organ systems. Oxidation in general is just not good. So again, it is part of an inflammatory response. Which then triggers an immune system response, leading to narrowing of the vessels via plaque accumulation, and inevitably that will calcify. So first it starts as a soft plaque and then it calcifies over time if we have a treatment intervention. So in short, so this is how I would sum it up. So we're taught our whole life that cholesterol causes heart disease. And I want to be as clear as possible, just through my understanding and interpretation, again, without being a physician. First of all, without cholesterol, everyone would die, and hence why we have it. So just to say inherently it's evil and bad is totally nonsensical. But what happens is it is a transport molecule. So it is a part of this immune system response. So when somebody, like Andrew said, most Americans are chronically inflamed. Guess what? Disease manifestation is happening. We're chronically inflamed for 20, 30, 40, 50 years. That's going to be a bad autopsy. Not good. So we have this chronic state of inflammation. And what happens? So it's going to create arterial damage. So what happens? The body has an immune system response to fix that. Hence why we had those mechanisms put in place. It goes to try to fix it and repair it, but you stay chronically inflamed. So what happens is cholesterol is coming part of the healing mechanism, but yet it gets vilified as the causal factor. So here's a good metaphor. Police are at the scene of an accident directing the flow of traffic, but they did not cause the accident. They came after the accident occurred. That's the same thing with cholesterol. The accident happens, it comes in there to help and fix it. So what happens? The inflammation, plaque over plaque. You have an immune system. So you have macrophages, lymphocytes constantly layering on top of each other, which creates that plaque in that lining. And then that's how you obstruct the blood flow, which then leads to ischemia, chest pain, and then inevitably an MI. So it's just important to kind of really wrap your head around all that. So hopefully that makes sense, my traffic scene accident, because I really kind of want that to sink in. Like, cholesterol is not the villain. Now, if you have oxidized LDL and you have a really high particle and you have a lot of small dents, then we got big issues. But it's not your LDL cholesterol. So hopefully that makes sense. Hopefully I didn't do a bad job explaining that. But Andrew will give me very harsh criticism after if I did, class, so don't worry about that. Almost done. I see Andrew getting ready to fire up to hit that unmute button. I know you guys saw it too. Conclusion. So again, many tools in the cardiovascular disease toolbox. I encourage you to use all of them. Again, have that open, honest conversation with your physician. Hopefully they're open-minded and not prideful. I'll let you guys take that battle because I've had those myself. So again, it's prudent to deploy all of them to get a sound clinical judgment with respect to the patient's disease risk. That's what it's about. You see your physician, they work for you, right? They're assessing you and your health and determining a treatment plan if need be. So again, they work for you. They gotta play ball with you and have those conversations. And again, so the point, the NMR Lipoprofile is one of the better tools and should be considered regularly when evaluating, diagnosing, or treating cardiovascular disease. And frankly, it's just not. It's glossed over. We don't talk about it. We're just doing a standard lipid panel, put you on a statin, check it in 6 months, see where your LDL is at, and go from there. I personally disagree with that methodology. I know Dr. Pardue does, because I've asked him point blank. So unfortunately, that is the quote standard of care in mainstream medicine. So my point in the nutshell is you are going to be the best advocate for your health, not your physician, yourself, because it's your health. It's going to determine your quantity and quality of life. So hopefully that makes sense to everyone and at least was moderately enjoyable. I'll take that as a victory. So go ahead, Andrew. You got something, buddy?
I've got a couple of questions just based on what I've seen from some clients and patients, but I'd like anybody else to ask if you've got specific questions about your labs. You ask those questions on your behalf first, and we'll see, like to take it to a practical level. Like, okay, I've got a high bullet BB sized LDL, what's my next step? So if anybody wants to jump in with whatever questions you have, please, y'all take it away. And then I can ask questions on people's behalf if nobody's got any.
I have a question.
Fire away.
You talked about the LP-IR. Is that on this result somewhere? I don't see it.
It should be. I know the ox LDL, but the LPIR should definitely be on there. So
I'm not seeing it.
Karen, I'm going to look at yours.
Okay.
Yeah. Okay. Thanks, Andrew.
So full disclosure, we've had some issues with LabCorp. I called one of their workers. They said, yeah, we've had a really hard time. They've missed several labs.
Thanks, LabCorp.
Yeah, it's a little bit frustrating. Karen, I don't actually see it on here either, but I know I've seen it on about 4 other folks. But Karen, okay, so here's a good example. So, and you've said I can use some of your information. So, with your other labs being considered, so we don't have that test because for some reason that didn't make it, even though it's part of the NMR. I have no idea how they ran your NMR without that. But anyways,
right.
And so, but there's a lot of ways to measure insulin resistance, right? I'm going to look at your A1C, your fasting insulin, and your fasting glucose. I'm going to look at all of those together. And guess what? You've got an awesome result on all of those. So your insulin's under 10, your glucose is under 100, your A1C is under 5.6, and you've actually been eating a pretty moderate to high carb diet. So you are actually you seem to be really insulin sensitive. And then your liver looks great on the standard panel, minus just that LDL is a little bit up. So.
Right. So I would, from a high level review, that looks very clinically low risk because all of her metrics are essentially optimal. So even with an elevated LDL, you could start to without knowing what her HDL and triglycerides are, you could speculate, since she is insulin sensitive, there would definitely not be an oxidized LDL manifestation.
Well, my triglycerides are real low, which is odd because my LDLP is sky high, very high.
What was your LDLP if you're okay? Only say it if you want to.
2014.
Ooh, doggy. Yeah. It's about double the threshold. Yeah, that is. And what was your triglycerides?
75,
Okay. And then the HDL?
68,
Very good. And then what was your LDL-C? What was that number on that?
162.
Okay. Yeah. Yeah. And then what was the size, the LDL size? Do you have that number, LDL size? Remember that pattern A, pattern B number?
21.4.
21.4?
Yeah, it's right down on the
Okay.
low end of good.
Right. So this is a good example. So you can have an elevated particle, which again is not optimal, but it seems like you have more of the benign particles in that particle totality, right? Does that make sense?
Not really.
Okay, that's fair. So you have elevated particle, but the sizes within those particles are more on the optimal side of that, or the lower risk side, if I can word it that way. So I'm not giving your LDL particle elevation a complete pass, but I'm not like, we're at DEFCON 2. I need to put you on get you on a statin and might as well give you a stent. Like I'm not there yet, just through my own professional lens, if that makes sense.
Right.
So remember, Karen, you got within those particles, you got the beach balls and you got the BBs.
The BB, yeah.
You've got a lot of particles in there, but you also got a fair amount of beach balls.
Correct.
Okay, so the P is just a measure of the number of particles.
Correct.
Regardless?
Yes. Yep. Correct. So you have a lot of cargo, but you have the better vehicles within that fleet of cargo, if that's another.
So what is the C, LDL-C again?
Cholesterol, LDL cholesterol. So it's basically all the cholesterol in a nutshell, as far as the total volume of all the cardio. But that's why it's important, though. You have to delineate. It must be, because again, you can have an LDL-C of a 90, but if you have all that's bad particles, that's means squat, which a 90 would be optimal is what I'm saying. So on paper, on that one panel, the standard lipid panel, your LDL could look benign on paper, but on a particle test, it could be malignant, essentially high risk, and vice versa as well. So that's why it's, again, important to use all the tools in the toolbox. Like you don't want to just go off of one value and say I'm good or bad. You can speculate, but then again, deploy the other ones to get an overall assessment on your clinical health.
So underneath that LDL-C, it has an HDL-C and a triglycerides. So, okay. So the LDL-C is the total cholesterol. Where do I get that it's fluffy?
In the particle test under, so NMR Lipoprofile test under the LDL size. So that 21, what'd you say, 21.4?
21.4, yeah.
Right, so you have more large pattern A, which is your large fluffy particles, the benign ones, the lower risk ones, which is good. So you don't want a whole bunch of vehicles, right? That's the particle number, LDLP. You don't want a big number there, but if you do, you want it to lean more towards the non-compromising size, with meaning the large fluffy particles. Does that make sense?
Yeah, so I've got a whole lot of cholesterol running through there, but it's really kind of good cholesterol.
Lower risk, large fluffy particles, correct, correct. Yes, yeah. Especially if that LPIR score is down towards the optimal end. Even more reason we don't have to be calling all cars there. Did we get that one for her, Andrew, the LPIR score?
No, so that's the one that they're missing. However, based on all your other metrics that would signal insulin resistance, Karen, you look pretty much like a 9 out of 10, 8.5, 9 out of 10.
Correct. And again, it's normal too, as you age, for LDL to increase. I mean, I've seen a lot of literature that's a normal part of biological aging, and there's different reasons for that. Again, I'd be more than happy to send it to Andrew. You can disperse it, you guys. There's a lot of studies. Again, when we start talking about vilifying cholesterol and eradicating cholesterol, and take these statins and put it in the drinking water and get your cholesterol down to 0 and you'll live to 1,000. There is so much documented evidence when you decrease cholesterol, you increase all-cause mortality. So dying from anything, particularly infection. So if you're older and you don't want to be immunocompromised, you do not want to start getting rid of cholesterol. So hopefully, it's like I said earlier, it's an important key to the immune system response is your cholesterol, because it is a transport vehicle and it is your friend. What happens, it's the things we're doing, smoking, like Andrew said, smoking, poor diet, sedentary lifestyle, family, those things is going to what transition the structure of the cholesterol to become oxidized or transition over to the harmful particle size, as in the small dents. It's those things that matter. So if we're smoking and we're eating high glycemic meals, like it's 1999, and we're just sitting around, watching Kardashians, you're going to have a bad particle test.
So what in your diet affects your triglycerides? Because mine really dropped.
Andrew,
it wasn't high. It wasn't high, but I had a significant drop.
Yeah. So the fastest way to get high triglycerides is probably, Matt, you can correct me if you have a different perspective, but is probably drinking a lot of like IPA beers. So the fastest way to get high triglycerides is to mess up your liver and then pour a bunch of sugar on it.
So I've quit drinking beer.
Yep.
It might be, well, so, or like a mixed drink with fructose and alcohol. So that's the fastest way. Yep. Now, I will say historically.
Well, when you say a mixed drink, I don't, when I have a mixed drink, I just have the shot of alcohol with soda.
Yeah,
soda water.
like an alcohol with sugar as well. So like sugary alcohol.
Okay, so it's the sugar
like a strawberry daiquiri, I think is what you're trying to say.
Yeah. Okay.
However, I will say, so historically, most of the people that we dieted, even if they weren't insulin resistant, we cut from their carbs, and that makes their triglycerides look a lot better. But also, I've dieted people who aren't insulin resistant. I'll diet from their fat, so I'll pull their fat down, just like we did with you, Karen. And that's actually where I've seen the best improvement in triglycerides, is actually taking away from both kind of carbs and fats. So
taking away carbs and fat, did you say?
And honestly, I think fats will make maybe more of I think, Karen, part of your response was that we pulled away from your dietary fat, which there's both carbs and fats, but I think it's like the really bad kind of sugar and alcohol, and then fats, I think, are the biggest contributors there.
Okay.
Yeah, but you got a great result, Karen. Everything's looking really, really amazing.
I concur with your assessment, Mr. Lawrence, about the alcohol and triglycerides.
Love it.
Yeah.
Well, I'm a random drinker, so I might go 2 or 3 months and not drink anything, and then go 2 weeks and have a drink every day.
Gotcha. Okay. All right.
So I'm random. I'm pretty random.
That's all right. Free will.
Anyone else have specific questions on their lab results?
Yeah, Andrew, I do want to be cognizant. I got to hop off in about 5 minutes to get to my next meeting. So
yeah. So Matt, let me ask a question on behalf of, I know some people that can't make it. So I'm sitting at home and I know I'm insulin resistant or I'm diabetic, and I've got a pretty darn high LDLP number. So like I'm over 1,000, maybe I'm over 2,000.
Right.
At that point, put me on like a decision-making tree. My next decision is probably to look at the LDL size, right?
Yes. Yeah. How bad are the particle elevation? Yes.
Right. Okay. So I look at the size of, what if it says low? What if it says, I've got that little bullet kind?
Hopefully we just acknowledge we've really backed ourselves up against a wall and we got to make a radical change.
Okay.
Hopefully bells are ringing like, okay, I'm getting disease and it's manifesting and I just got proof. Like I need to take care of this now.
Okay. What are some of the first steps you're doing to take care of that number and to put yourself in an improving position?
Yeah. So a lot of it goes back to the pillars, but to get specific, strength training, consistent, regular strength training 3 times a week, 20, 30 minutes minimum. Diet's so I want to reduce inflammation at a minimum from the foods I put in my body. So foods that we've talked about, particularly high glycemic, starchy foods, are going to create an increase in inflammation. So you want to eat foods that are anti-inflammatory, particularly rich in omega-3. So I'm a big avocado fan, like my silly cliche, cliche saying, an avocado a day keeps the doctor away, not an apple, an avocado. And there's very good monounsaturated fat in that avocado, which again is going to have omega-3, which not only reduces inflammation, but it helps increase your HDL and reduces triglycerides simultaneously. So you have like a 3-fold factor there: reduction in inflammation, increase in HDL, reduction in triglycerides from the bile composition of an avocado, if that makes sense. So again, good quality, clean foods. Again, particularly to whole real foods, I think it's lost a lot. Whole real foods matter. You know, very few ingredients, closest to its natural pure state found on Earth. You know, not a lot of processes to break it down, not a lot of additives, preservatives, chemicals, dyes, hormones, and the list goes on, like a grass-fed beef that we talk about. So that stuff matters. So really clean up the diet. And again, a big part of that is going to be sleep. You know, we can't undermine and neglect sleep. We could probably take a position where sleep is probably the most undermined component of one's health and wellness. So the point, I guess what I'm trying to say is it takes a lot of work to be healthy. And if you want to really be healthy, you got to be engaged and willing to put the work in. Does that answer your question in a roundabout way, maybe?
Yeah, I think so. Yeah.
So a lot of omega-3s and very little omega-6. Again, I want to hit that home. So that's very important. A lot of omega-3, very few omega-6, which is your industrial seed oils, your soybean oil, canola oil, safflower oil, sunflower, all that negative Ghost Rider, because that's going to create a very high inflammatory response, which then triggers the free radicals, oxidation. You just don't want to do that, which is in everything in a box or process just about. So again, the ingredient list matters when we're putting food in the mouth. Let food be thy medicine, right? Who said that? Was that Socrates? Let food be thy medicine?
Yeah, and thy medicine be thy food.
Yeah, exactly, yes.
And Maimonides, so broad agreement across cultures in the ancient world. Hey, so that's really good. I think I like a practical takeaway from this is find behaviors and things that you can incorporate into your life to radically reduce your inflammation, and let's get your insulin resistance under control. So if I'm just going to list off a couple of things that I do with my clients to decrease inflammation, you know, manage your stress, which we could talk about, but sleep better, strength train, and then one that I would definitely do is omega-3 fish oils and reduce those omega-6s. Those are all huge pieces to that. And then frankly, put yourself in a position where you can diet for a really, really long time, get some fat off your hips and off your belly, and that's going to significantly decrease your inflammation as well. So,
and just one last point before I go, inflammation is the pathological precursor to virtually almost any disease state. So inflammatory regulation and management is critical to quantity and quality of life. I mean, rheumatoid arthritis, osteoarthritis, anything with inflammation, cardiovascular disease, inflammation, diabetes, inflammation. And there's other tests too, like a C-reactive protein we can measure. So there's a lot, we could do a lot more of these video, and maybe we should if the group likes me enough to do more. We'll see. The jury's still out. So, but just really managing the inflammation in your body is going to radically transform your life. I mean, the less inflammation you have, you'll probably be more excited to wake up the next day. Can I say it that way, Mr. Lawrence?
Absolutely.
Cool. Well, guys, I do have to hop off. I'm sure Andrew can tell you a weekend story to keep you entertained for the last couple of minutes here. I do have to go to a meeting, so I just want to sincerely thank everyone for your time. Hopefully you got a little something out of this conversation, and at the end of the day, hopefully it wasn't a waste of time, because I do appreciate what you're doing. So thank you, everyone.
Thanks, Matt.
Hey, thanks, Matt. Appreciate it.
Thank you, Lindsay. Thanks, Mr. Lawrence. I don't know why I always say Mr. Lawrence. Unreal. All right, guys, I'll see you.
Thank you.
Bye.
I'll stay on here for a couple minutes for any follow-up questions y'all have. And by the way, I got another message from somebody that I missed. LabCorp really didn't attach this to several people, so I'm gonna be definitely fighting to make sure if you're watching this at home, you didn't get a video or you didn't get a lab result that you expected, let me know, because I'm going through and making sure that LabCorp took care of that. So. Dina, how you doing?
I'm doing
When you're
great.
going back,
Did you ever get my stuff in? Because I can't see it.
I didn't get your NMR just because it was yesterday morning. It usually takes more than 24 hours to get the NMR in. But I will say, Gina, if I can celebrate a little bit with you, you got your lowest LDL ever since I've seen you. Right?
Good. Well, I'm on a statin though, Andrew. So.
But even on that statin, you've not seen that. Now, even on that statin, you've been much higher than the number you've got.
Right.
Yeah.
I do have a question.
Yeah.
Many years ago, and I can't find the test. My doctor, I gave it to her. She couldn't find it. I think it was, I mean, it's been probably 15, 20 years. I did a calcium score because I had a friend who worked for UT and they were doing a friends and family event and it was very cheap. So I went over and did it. And as I remember, I was in a moderate range for calcium. I was in the
Really?
moderate range. So that was, you know, a concern. So I'm seeing my doctor on Friday. I'm going to ask her if she thinks I need to have another one done just to
Yeah.
kind of see where I am.
Tell me again, how many years ago was that?
It must have been, I don't know, Andrew. I would say it's somewhere here in my house. That's another thing I'm getting ready to do is my filing system.
Like 5 years ago,
But,
10 years ago?
Oh, yeah, it was over 10 years ago.
Okay, yeah, if you were moderate back then, I mean, we're gonna get your results in, so we're gonna see. But again, even if, because you've got your best LDL result ever just recently, you know, like maybe in the past, your NMR results would have looked a little bit worse. So it still probably is gonna be worth maybe doing another calcium score. Calcium score is just like a cash-based procedure. And even like 5 years ago, it was like 800, 900 bucks. But in that time, it's been so popular. There's now like 4 or 5 places in Knoxville on one street you can get it. So it's down to like 100 or 85 bucks or something. The market
Yeah,
has really driven the price down on that.
Mine only cost $100. It was a special event that UT was doing. And so mine only cost $100 and I did it.
And I think that's pretty much what it's going to be now.
Yeah,
Right.
Gina, I went and had one about 20 years ago too. And I just went down to my physician told me I could just go down to UT and ask for it, call them and ask to get an appointment for it. I didn't have to, you know, so I did that and it was less than $200. I feel confident in it, but it was UT there in Turkey Creek.
Yes, that's where I went. And I was going to ask her on Friday when I see her about that. And also I haven't been back to my cardiologist in probably 10 or at least 10 years because some of the tests he did, he told me I had the heart of an 18-year-old. He said, don't come see me unless you need to.
Nice.
But I feel like I should every now and then have a test, you know, be seen. I don't know. Because of my family history, I guess. You know, my father passed away at 59 of a massive heart attack. So, and my mom also had 1 or 2 heart attacks in her life.
I mean, if it's mom and dad, that's going to be pretty much my number one.
Yeah.
So.
Okay.
Anyone else? Pam, Horace, and Sally. I know Amy had to dip out a second ago.
One thing I remember about that calcium score too, it's age-based. So the rating that they give you, they'll rate you at a certain age, cardiovascularly.
Yeah.
So, you know, I just remember they rated me, you know, at a certain age of having a heart at the age of blah, blah, you know, which at that time, 20 years ago, it was a heart of a 74-year-old.
Seriously? Well,
yeah, well, my mother dropped dead of a heart attack at 56.
Wow.
So,
yeah, I know you're already, so, okay.
I mean, there's not anything you can do about your genetics, you know, but try to know that you've got to live the healthy lifestyle because of it.
Yeah, and Karen, seriously, you're looking really, really, I mean, you're across the board, you're just looking very, very sharp. So I'm really, really pleased with that. And we've just started dieting. So that's incredible.
Well, I have a family history. Can you hear me?
Yeah.
My dad had a heart attack. He was probably 80. He was older. My mother had a stroke, massive stroke. And my mother's father had a stroke, but they were all older. I've got cancer, cardiovascular, I've got everything.
Yeah, and again, though, going back to like sort of first principles, like what's happening in our bodies, because we got all these chronic diseases, diabetes, heart disease, cancer, and all those things. Well, again, like Matt said, inflammation is the root cause of all that. And guess what we've learned recently is that cancerous cells, so cancer cells of pretty much without exception, all the really dangerous cancers, right? So all of us have cancers in us, but they're only, it's a small percentage of cancers that are really, really dangerous. Well, of the dangerous cancer cells, and this one is like a really big wake-up call for a lot of people, they feed on sugar. And so if you can literally in a lab, you can take a petri dish of those cancer cells and sprinkle sugar on them, and they grow to fill the whole dish. Whereas if you feed them fat, cancer cells don't grow, they even die. So if you are diabetic and you've got chronically elevated blood sugar, that's a ready available food source for cancer cells to just absolutely multiply. And so even now, the standard of care for chemotherapy is to do a fasted chemotherapy, because the fasted chemotherapy takes the sugar out of the system. The cancer cells begin to shrink without their favorite fuel source, and then chemo really blasts them. And so blood sugar control is absolutely critical for like decreasing cancer risk, and like we saw, like heart disease risk. So definitely something to think through. Again, diabetes in and of itself is like just sort of painful, and it'll rob you of your energy. The problem with diabetes is that it just feeds all the other major sort of killers. So, all right, y'all, this was an absolute blast. If you have outstanding questions and you are on this call or you are watching this recording, please make sure you get those answered. We'll obviously, if we got a lot of people with the same question or with other questions, we'll do another call on the same topic. But go ahead and email us those questions. If you're going to your physician soon and you'd like to bring your results that you've just gotten, we'll make sure that you have them. If you're about to, if you haven't gotten this lab or these results and you want to get them and you want to figure out the best way to coordinate that, just let us know and we'll make sure to get you set up on that as well. So yeah, this was great. I hope y'all enjoyed it. I've really been looking forward to this, and we're incredibly excited about making this panel the standard of our care, and we think that's going to set our clients and patients up for success, and we're doing everything we can to drive that cost down so that you guys can get it whenever you want at a very, very low cost. So anyways, we expect to get it lower, cheaper than $80, but for now it's going to be a little bit more expensive for us to coordinate. So any last thoughts? Lindsay, if you can stop the recording and just send it to me, I'll go ahead and put it on YouTube and send it out on Facebook and email today.
Yep, I got you. Thanks,
All right.
everyone.
Thank you, Lindsay. Y'all have a great week. We'll be in